Let's get started. We are shifting now from pre-event discussions to post-event, MCM use, medical countermeasures use, and research in post-event scenarios. And we will, again, the format, we'll ask each of you to make your presentations and then open it for questions. First will be Captain Carmen Marr, Deputy Director of the Office of Counterterrorism and Emerging Threats within the U.S. Food and Drug Administration. In this role, Captain Marr assists in formulating counterterrorism policy and provides leadership and direction to the Office of Counterterrorism and Emerging Threats, as well as the FDA Medical Countermeasures Initiative. Captain Marr also advises and collaborates with senior staff in developing, updating, and implementing medical consequence management and mitigation programs, policies, and plans for response in public health emergencies. Welcome, Captain Marr.
Thank you very much, and thank you for inviting me here to speak with you today. I was asked to comment or be specific about the regulatory landscape for providing medical countermeasures to children in an emergency, and so that's what the focus of my brief remarks is going to be. The first thing I did want to share, and this is something that it's a slide that we have with almost all our presentations when we talk about medical countermeasure use in emergencies, and it's the FDA balance that we strike when we're evaluating and in doing that risk-benefit analysis with regard to either authorizing use of an emergency medical countermeasure for the population or the reviewers when they're looking at individual EIND use for an individual patient. And we balance the public health or the medical need, whichever may be the case, against the regulatory requirements and the scientific evidence or the scientific data that we have regarding the product and regarding the intended use. We're also looking at the circumstances of the emergency, which, depending on the situation, the risk-benefit assessment might change. Our regulatory mechanisms for utilizing medical countermeasures in an emergency include the Investigational New Drug Application, the IND, the IDE for devices, Investigational Device Exemption, and we also have, as been spoken of today, the Emergency Use Authorization. With regard to the IND, it's the same mechanism that we have that allows use of an investigational product in humans for clinical trials. But as you can see, we can also use it if needed during an emergency. In some circumstances, the IND might be the most appropriate mechanism that we have for the investigational product. We can use it for individual patient access, which is the EIND. We can use it in an expanded access trial for intermediate-sized patient populations. And we can also use it in a treatment IND or a treatment protocol under IND. We also have, for larger scale events and for authorizing wide-scale use of either an investigational product or an unapproved use of an already approved product, the emergency use authorization. A couple of nuances with it. It requires a determination and a declaration under Section 564 of the Federal Food, Drug, and Cosmetic Act. In order for the EUA to be utilized, it must meet 4 conditions for authorization. There has to be a serious or life-threatening condition that's caused by a CBRN agent. There has to be a reasonable belief that the product may be effective. The known and potential benefits of using the product outweigh the known and potential risks of the product. And there's no adequate, approved, or available alternative to the product. One of the benefits of emergency use authorization, particularly when you're talking about a large-scale response, is that it does not require informed consent or IRB review, even though you would be using a product that is technically investigational or unapproved for the intended use. It does require sufficient scientific evidence to support the intended use of the products, and for some products, there may not be sufficient scientific evidence to support that use under an EUA, and that's where we are with the ABA vaccine in children. There are many medical countermeasure challenges in pediatric populations. A lot of them have been discussed at length today. With regard to the EUA, in order for us to authorize use of a product under EUA, in addition to the scientific evidence that we mentioned, or that I mentioned, the potential benefits must weigh the potential risk, and you've had a lot of discussion today about the difficulty in making that risk-benefit assessment before an emergency because of the uncertainty of the risk, and even during the emergency because of the uncertainty of the risk. The IND mechanism requires informed consent and IRB approval. During large-scale emergencies, obtaining this might be difficult. It could hinder the response. We've collaborated very closely with the CDC and with state and local partners to understand what the limitations of on the ground are with regard to a response, so that we can consider that as we're looking at particularly the IND for AVA use in children. There is a need for clinical studies, and I did want to point out, I stole this little bullet from a colleague of mine, Rich Gorman, from his slides at the FDA-sponsored Pediatric Medical Countermeasure Workshop. A lot of the information that we have about the use of products in children, a lot of the use is off-label, but a lot of the information that allows us to use the product is extrapolated information from adults. Either we've extrapolated the information and labeled it for children, or it's being used off-label based on information that a prescribing physician may have in front of them. When you talk about CBRN medical countermeasures and the difficulty with developing those, you're talking about medical countermeasures that can't be tested, or the efficacy cannot be done in humans. Safety, you may have a very limited safety database. So you're talking about extrapolation not from adults, but from animals and then adults to children. So it becomes even more difficult. There's extrapolation from adolescents to toddlers and infants, but still that is an extrapolation of the data. There's modeling utilized as well, which adds complexity, even though it does inform. There's a need for bridging studies, safety studies, and there's a lot of endpoint issues when you are dealing with clinical trials or studying medical countermeasures in pediatrics. And I wanted to keep this very, very brief. Regulatory presentations tend to be long, boring, and dry. So I'll be happy to answer any questions you have at the question and answer session.
Thank you very much. And next we will hear from Dr. Sonia Rasmussen, who is Deputy Director for the Centers for Disease Control and Prevention's Influenza Coordination Unit. She's authored 12 book chapters and over 160 peer-reviewed papers related to this. Dr. Rasmussen has received numerous honors, including the Arthur S. Fleming Award in honor of outstanding men and women in federal government. She participated in planning for a future pandemic and subsequently in the response to the 2009 H1N1 influenza, focusing on influenza's impact on pregnant women in particular. Welcome, Dr. Rasmussen.
Thank you. It's my pleasure to be here today to talk about some of the clinical research that occurred during the 2009 H1N1 response. And just to remind you of some of the timeline associated with that outbreak, in April of 2009, 2 patients from California were identified with a novel influenza A H1N1 virus. On April 26, 2009, the U.S. declared a public health emergency. April 27th, 29th, and June 11th, the World Health Organization raised from global pandemic level 3, where we had been because of H5N1 in Asia, the avian flu, to phase 4, 5, and 6, and 6 is a full-blown pandemic on June 11th. And then August 10th, WHO declared end to the 2009 H1N1 influenza pandemic. What was the impact in the United States? These are estimates, 61 million cases, 274,000 hospitalizations, and 12,470 deaths in the United States. And I think it's important to note that the distribution of deaths was different from what we really saw typically with seasonal flu, which is an emphasis on primarily older people. There was a big emphasis, you can see, in the almost 10,000 deaths in 18 to 64-year-olds. So I'm going to use 2 examples here. One is use of intravenous antiviral medications in critically ill patients, and the other is use of antiviral medications in pregnant women. The first issue with intravenous medications, there was no FDA-approved IV influenza antiviral medication for treatment of severely ill hospitalized patients at the beginning of the pandemic, and that's still the case now. There was a question of whether oral oseltamivir can be adequately absorbed in critically ill patients. And the other medication to which the H1N1 virus was sensitive, zanamivir, inhaled zanamivir, is contraindicated in patients with airway disease like asthma, so that takes a lot of the population out, and patients that are mechanically ventilated, for example, in an ICU. So the potential emergency use was investigated, which possible IV neuraminidase inhibitors could be used, and HHS decided to acquire peramivir, and FDA issued an EUA, you've already heard about EUAs, on October 23rd, 2009, and that was terminated on June 23rd, 2010. This was the first time an investigational, unapproved drug was authorized for use under an EUA. CDC was responsible for distributing the medication, peramivir, and they developed an online system, the Peramivir Electronic Request System, for clinicians to request peramivir for individual patients. And really the goal here was to get that medication that might be life-saving, to patients that were critically ill. So the point was to ensure equitable, rapid access, and to get patients who needed the medication. So there was web-based information for healthcare providers. CDC conducted 3 post-release follow-up surveys. We received 1,371 requests for peramivir through the EUA program, and over 2,000 adult treatment course equivalents were delivered. It's more than the number of requests, because sometimes requests were for 10-day courses rather than 5-day courses. They were delivered to 563 hospital pharmacies in the US and Puerto Rico within 24 hours of request, and the median delivery time was 12 hours. So the goal really was getting that medication to critically ill patients quickly. There were, as part of these surveys that were done afterwards, 1,274 distinct peramivir recipients were identified. This slide shows the frequency of peramivir administration during the EUA and compares that to the % positive influenza tests reported to CDC, and you can see that these two things mirror each other. You can see the EUA was issued on October 23rd, 2009, and you can see there was a rapid increase in requests for peramivir, of distribution of peramivir, and then dropping off as the pandemic slowed down. And here, I think this is helpful because you can see these are sick patients. 92% were intubated, 23% were on dialysis, 50% were on pressors. And then you can see the data at the end. The difficult thing is that because of the way this was done during an event, during an emergency, we don't know if the fact that it appears fewer people in an ICU, fewer people intubated, fewer people on pressors to support their blood pressure after they got peramivir was related to the peramivir or not. Same thing, you see 23% on dialysis at the beginning, 29% after. Did that have anything to do with the peramivir? It's difficult to know. And that was based on 127 responses to a clinician survey. So that was a very small proportion of the number of clinicians that actually received peramivir. These are data from the adverse events reporting system at FDA, and this is the way the data was planned to be received as part of the EUA. And here you can see adverse events by the preferred term. This is MEDRA term. And then the different adverse events. And I don't want you to look at all of these, but just to see that most of them are really things that you'd say, well, that's part of being really sick with influenza, death, H1N1 influenza, ARDS, acute renal failure, cardiac arrest, et cetera. And the FDA experts that analyzed these data, the only adverse event that they were able to clearly associate with peramivir use was rash. So the conclusions about research in peramivir: many recipients were critically ill and at risk for influenza-related complications. Rash was the only treatment-emergent adverse event that was attributable to peramivir. It's difficult to distinguish between what was really just severe, being really sick with influenza, and what was due to adverse events. And the data collected were insufficient to assess whether peramivir affected outcome, did it make people better or not, or whether it caused adverse reactions other than rash. Then I also wanted to talk to you about the use of antiviral medications in pregnant women. And we knew before the pandemic, based on previous pandemics and from seasonal influenza experience, that pregnant women are at an increased risk for complications related to influenza. However, there were limited data available on the use of antiviral medications for treatment of influenza during pregnancy. And I just want to note that this is really true for almost all medications that are used during pregnant women, that we don't have enough data to know whether those medications are safe. So antiviral medications weren't really that different. We did have a meeting about a year. It was April of 2008, and that's the paper you can see at the top. We had a meeting at CDC and brought in a number of experts and partners to work on preparing for a pandemic, to review the data that were already available and plan for a future pandemic, what sort of recommendations would be made. That paper, ironically, I got the galley proofs for that paper the same week that the MMWR came out about the 2 children in California. But it meant that we did have information, we had well thought through information for recommendations. Unfortunately, it meant that we hadn't, some of the research that had been called for in that paper obviously had not had time to be done. So our treatment recommendations were to treat with oseltamivir for pregnant women and for women up to 2 weeks postpartum, regardless of pregnancy trimester, and to not delay treatment based on negative rapid influenza diagnostic tests or inability to test, or while awaiting test results. Physicians were recommended to use their clinical judgment of whether the patient had flu. We have some data about what happened among pregnant women. These are data that were collected at states and then sent into CDC. So this is really the work of states that worked very closely with CDC on influenza surveillance during the pandemic. 5% of deaths in the United States from 2009 H1N1 were among pregnant women. And pregnant women account for about 1% of the general population, so it shows a higher proportion of pregnant women affected. We also found that early treatment with oseltamivir was associated with fewer ICU admissions and fewer deaths. And this, just quickly to show you I don't have a pointer here, but the top layer there, you can see women who received oseltamivir or an antiviral medication 5 days or more after symptom onset compared to those that received it in the first 2 days were 6 times more likely to be admitted to an intensive care unit and 53 times more likely to die. You can see a very broad confidence interval though, because fortunately there were not very many deaths. And these are observational data, so these are not the same as data that you could collect in a clinical trial. So conclusions about influenza antiviral medication, we have observational data that suggests that pregnant women who received antiviral treatment were less likely to die and less likely to be admitted to an ICU. But knowledge about the pharmacokinetics, which we know pharmacokinetics are different in pregnant women, and about safety of medications during pregnancy remains severely limited. So our overall conclusions: collecting data on safety and performance of medical countermeasures during a public health emergency is challenging. And I was actively involved in the part of pregnant women, and we were working as hard as we possibly could, and it was hard to collect the data that we had. Investigators are often actively working on response activities, making sure that people get the treatment that they need. The goals of providing rapid, equitable access to medical countermeasures may conflict with the goal of performing research. Research studies in the midst of a response might be perceived by the public as using countermeasures that are not safe, and then possibly decreasing the adherence to public health recommendations. And then just a question, can adequate informed consent and for research studies be obtained in the event of a public health emergency response? Just a few more comments. Preparedness is key. If we're going to try to do something post-event, I think you really need establishment pre-event of mechanisms such as clinical networks and mechanisms of ways to pay for things in the government to conduct real-time or near real-time safety and clinical evaluations of those investigational medical countermeasures. A systematic mechanism for rapid review and analysis of those data collected is needed so that they can continue to inform guide usage as the event goes on, and studies would need rapid institutional review board review that could be facilitated by a central IRB. And I just wanted to acknowledge Denise Jameson and Yan Yu. And Yan Yu is one of the people that was very involved with the EUA program for Peramivir, and she lent me her slides. So.
Well, thank you. Thank you, Dr. Rasmussen. And the final speaker in this particular panel is Dr. Suzette McKinney. Dr. McKinney is Deputy Commissioner for the Bureau of Public Health Preparedness and Emergency Response and Division of Women and Children's Health at Chicago Department of Public Health. She oversees preparedness efforts there for the department. In this capacity, Dr. McKinney is the principal investigator for preparedness programs funded by both the CDC and the Office of the Assistant Secretary of Preparedness and Response. She has been the primary force in the development of public health regional plans in Illinois to respond to bioterrorism events and other public health emergencies, and has contributed to numerous programs on public engagement and distribution and dispensing of medical countermeasures. Welcome.
Thank you very much. It is indeed an honor to be here to speak with you this morning. I was asked to talk about the challenges associated with local level implementation of the current regulatory framework that the Commission is considering for delivery of medical countermeasures in children in emergencies. So I'd like to start today and frame my discussion around the lessons that we learned here in Chicago from 2 real-life events. Once I describe each of these scenarios, I will go into some challenges that we faced in each of those response efforts, and then also some potential improvements or suggestions. In 2008, the Chicago Department of Public Health's Bureau of Public Health Preparedness and Emergency Response, along with our immunization and communicable disease programs, initiated a mass vaccination campaign that was designed to increase vaccination rates against meningococcal disease in children ages 11 to 18 in 2 Chicago community areas. This campaign was initiated out of an abundance of caution, but that was after the recognition of increased incidence of meningococcal disease within these 2 community areas, as well as 2 deaths associated with this increased incidence. The campaign required a multidisciplinary response, which included state and local public health, law enforcement, public school officials, as well as private and parochial school officials and other stakeholders that were instrumental in assisting the department with its vaccination effort. The campaign lasted for approximately 18 days and included both in-school and community-level vaccination sites covering over 65 schools. In the end, there were nearly 7,000 vaccinations that were provided, mostly to children, during this campaign. However, the number vaccinated represented only about half of the intended population that we wanted to reach. In this effort, we were providing an FDA-approved medication that is also recommended for this age group by the Advisory Committee on Immunization Practices. However, this operation was still hindered by a perceived lack of urgency or need, poor perception of the intent by parents, some school officials, as well as the intended population. This made the ability to obtain parental consent particularly difficult, despite a full media campaign and joint coordinated messages that were being disseminated by Chicago Public Schools and the Chicago Department of Public Health. It is very important to note that the 2 community areas in which we were operating represent multiple levels of vulnerable or at-risk population groups, primarily pediatric patients, low socioeconomic status communities, as well as primarily African American and Hispanic communities, which in our experience are subpopulation groups with high levels of false perception of governmental intent and consequently mistrust. During the 2009 H1N1 response, our health department provided antivirals to physicians' offices, community health centers, and federally qualified health centers. Those antivirals were provided to physicians' offices under an EUA. Hence, patients received medications for the most part in their medical homes, which we believe perhaps minimized some of the anxiety around the medication. But in the fall of 2009, once the vaccine was available, our health department provided vaccination to city residents under multiple mechanisms, servicing any resident voluntarily presenting for vaccination for either themselves or their children. This response effort was also a multidisciplinary response, but one that also garnered local, national, and international attention. However, despite widespread media coverage of the event and what should have been an obvious and real threat, Chicago experienced poor acceptance of the vaccine in specific at-risk population subgroups. Once again, we saw many of these groups as being primarily African American or Hispanic and low socioeconomic status communities. There was particular concern from parents around the intent for the need of vaccination in children. It was our experience that stigma associated with the Tuskegee experiments and the misperception that vaccines create autism and other adverse health events in children further hindered our ability to relieve parental concern about the safety of the vaccine, as well as what our intentions were in terms of securing full participation in the vaccination effort. So in each of these response efforts, there were logistical and operational challenges, mostly related to the large numbers of persons requiring vaccination and consequently the number of vaccination locations. However, these are challenges that we plan and prepare for on a daily basis, so we did not find them as daunting as one might think. In both situations, public acceptance of vaccination was poor due to numerous factors, but most frequently religious beliefs, poor perception of both threat and governmental intent, as well as an overall mistrust of what our governmental efforts were at the time. As with any situation, we found that communication was particularly difficult due to the myriad of ways that members of the public tend to access information and receive information. No matter how widespread our communication efforts were, we found that there were pockets and areas that were missed among particular subgroups of the population and also subgroups who simply did not heed the messages that we were attempting to deliver. In Chicago, we also experienced difficulties associated with the legal interpretation of the emergency use authorization. Differing interpretations among multiple attorneys in the absence of clearly defined guidance for EU implementation and physician accountability required additional examination and hence caused some delay in the delivery of countermeasures to provider offices. In the event that the U.S. government makes a determination of the need for AVA in pediatric populations, it is our belief that the challenges that we've seen in these two events will be repeated and further complicated by questions surrounding the different regulatory policies for adults and children. In the case of EUAs, clear, specific guidance for implementation to minimize the varying interpretations that we saw here during the H1N1 response effort. There will be no simple explanation for why MCMs are delivered under one mechanism for adults and yet another for children. However, clear, specific, and coordinated messages across all levels of government and the healthcare sector may alleviate some of the anxiety. The availability of medical countermeasures in public pods as well as in physicians' offices, as was done with the H1N1 vaccine, may also alleviate some concern for parents with regards to their children. Building upon the H1N1 experience, we believe that local and state public health, working in conjunction with the CDC, will be well equipped to accommodate this type of scenario. The risks associated with pediatric administration of the vaccine will need to be specifically addressed for parents. This should include multiple venues for discussion and a clear comparison of the advantages and disadvantages of the vaccine in pediatric populations. Without a real, credible threat or perception thereof, even the most aggressive and comprehensive efforts will be met with anxiety, fear, protest, and apprehension. Thank you very much.
Thank you. Thank you all three. Actually, I think Nelson got his hand up first, and then we'll go to you, John.
Thanks to all three of you for great presentations. My question is to at least Dr. Rasmussen or perhaps others, but I'm particularly interested, based on the information that you showed, about what your view would be of the feasibility of actually doing, in a bioethically robust way, a pre versus a post-event study that will be looking at things that will be relatively arcane, like dosing and immunogenicity studies of AVA, not the kinds of studies that would be particularly what the public might be more expecting that we would ask in terms of efficacy, but in terms of more arcane questions.
I don't know that I have the ability to tell you. You're asking, so you're asking my sense of how this sort of study would go pre-event?
I'm asking how you could imagine the robustness of a bioethical framework for a study done pre-event versus post-event. That would be, say, a relatively small study of several hundred individuals, children, where you would be asking questions not of efficacy or even of significant safety questions in a study of that size, but would be asking questions of dosing and immunogenicity, which is really what we're talking about in terms of AVA. So, and I'm asking this because of some of the questions that you raised, or some of the testimony that we've heard from the three of you about the feasibility of executing some of the science in the context of a post-event study. What would be the balance, obviously, between now a much greater idea of risk, because now you actually have an event, versus the informed consent process that might be a little bit pressed because of the situation of an acute event? Do you think that the bioethical framework of asking that kind of question is going to be as robust in a post-event scenario as in a pre-event scenario? And I think the counterbalance is you're not asking a question that necessarily is going to get to efficacy, much like the neuraminidase inhibitor study that you showed. You couldn't get to an outcome, okay? So you're going to be asking questions really that are more arcane and in my view might be more difficult to explain to potential research volunteers and their families.
Yeah, I am not a bioethical expert. I'm a epidemiologist and pediatrician. I think that parents, at least in my experience, can understand if you take enough time and you speak in words that they understand. I think parents, before I went to medical school, I was a genetic counselor. I think families can understand just about anything you have to explain to them, and I think they can make an informed decision if the informed consent procedure is done in an appropriate way. We oftentimes in genetics explain very complicated things, and families, I think, are able to follow it and make decisions that work for them. So I think from that standpoint, it's doable. I think the side of things that I worry about in a post-event structure is how hard it was for us to do something in a post-event. Now, again, I think you think, well, all these people are getting this vaccine, we can study all of them, but that's not going to be feasible in a post-event either. We're going to have to narrow down to a fairly small number of people that can be consented to be part of some sort of study. So I think you're still probably not answering all the questions that you would want even with the post-event study with smaller numbers. I don't know if that answers your question.
That's a tough one.
Yeah.
John, how about something easier?
You can always turn to me. This is just a point of information from Captain Marr. What does it take to get bumped from IND status to EUA status? So I heard you say, I think, that that to get EUA status, you have to go through some hoops and you've got to present some real scientific information, but we're not getting the usual meat and potatoes here. We're not getting safety efficacy. We're just getting, at best, from the pre-event study, immunogenicity, dosing. So just as a point of clarification, is that sufficient to give you EUA status?
The specific amount of scientific evidence or data that you would need for an EUA is going to depend, and I know that this is not going to be a satisfying answer, but it's going to depend on the intended use of the product, the population that you're intending to use it in, and what evidence do we have to support that use. And as products are being developed down the pipeline, especially the investigational products, there's a constant look at what the scientific data is showing us about the product, the preclinical data, the early clinical data, and an evaluation of at what point do we feel confident that the data that we're looking at allows us to reasonably believe that the product would be effective for the intended use in the circumstances, and that's the data that gets you to EUA.
Alex. I'm sorry, Christine was next. I'm sorry. Then we'll go to Alex.
Thank you all. I wanted to pursue one, just, I guess, also pretty technical question that I have. I've heard it said before, and you said it very clearly today, the difference between using an EUA afterwards and using a research IND would mean consent from the parents and an IRB review. So my question really is, even with an EUA, wouldn't we need consent from the parents? And is the difference just written or not written, or is there no difference? That's one question. And the second is, couldn't IRB review and approval happen earlier, at least for the most likely protocol that we would use and be ready to go? And so in other words, how much of an obstacle are those two things, I guess is the question.
Thank you. And from the perspective of what we're planning to do with AVA and how we use INDs in emergencies, I do want to make a distinction between a research protocol or a protocol that's designed to generate data about the use of the product versus allowing access to the product. And what we're planning on doing, and the pediatric IND is a completely access IND. The reason why we have to do it under IND is because, as I mentioned before, there's no sufficient scientific evidence to support its use under an EUA. We don't know the safety. We don't know anything about the use of the product in children, and there's very limited information to extrapolate, if you could extrapolate that information, and it may not even be sufficient. We have met with CDC and state, local, tribal, and territorial partners to understand the limitations on the ground and the differences between EUA and an access IND. The information about the vaccine, what we know about the vaccine, what the components of the vaccine are, I heard that that's something that would be asked, is probably the same information that you would be providing under an EUA, which requires you to inform certain information to the recipient, and then the recipient can elect to take the product or not, versus the IND, where you have to actually get, from what I understand, a signed informed consent, the typical informed consent, not your 8-page informed consent with all your basic and additional elements. Very similar, perhaps, to the EUA fact sheet, but designed specifically for the IND and to obtain informed consent from the parent.
Interesting. Oh, did you answer the question about an advanced IRB? Okay.
We have, as part of the medical countermeasure pediatric workshop, one of the things that we wanted to understand, and we brought experts in to discuss, was the situation with the IRBs and the difficulty. Theoretically, if you could pre-position a protocol, have it approved by the IRB and ready to go, then you would be able to do the research intra-event. We actually, with Sonia, we have FDA, CDC-led intra-event surveillance action team that's actually debating all of these questions, looking at the current way safety, efficacy, and use of the product is evaluated, how we used some of those surveillance mechanisms during H1N1 and other emergency responses, and what can we do to stand up either pre-event protocols, intra-event protocols, which would include how do we get to that pre-IRB approval.
If, God forbid, there were an event tomorrow, what would we have to do? We'd have to constitute an IRB and a protocol, and I mean, what would we have to do to be able to give the vaccine to kids? Because I understand that's the plan, that we would give it to kids even without data.
Currently, As far as I'm aware, the CDC and FDA are already working on the access IND, the development of that protocol for access, the development of that consent form. There's also work going on with regard to developing a nested research protocol to look at, within a subset of the children that receive the vaccine, to study immunogenicity and reactogenicity, to further inform and maybe get us somewhere else with the product. If it is an IND, it would require IRB review.
Well, Christine stole my question about what would you do today. So, but no, but I have other ones. And well, it sounded, maybe you could clarify this. So it sounded like there's minimal difference though between an access IND and an EUA. Is that correct? What you were saying? It sounded like it was the same sort of information that was being given to parents about the vaccine, risks, adverse events, things like that. But one was more formally titled as informed consent, and the other one is kind of a FYI.
And there might be a little bit of different information with regard to the use in pediatrics, what we don't know, that would be included in the informed consent about that population than what you would see in the EUA fact sheet. But for the purposes of an anthrax response, understanding all the limitations that we have, the speed with which one needs to respond, the desire to vaccinate as soon as possible, and the desire to be able to protect all the population, including children and pregnant women. We have been very careful and listening to the input from our state and local partners of the limitations and the difficulties that the informed consent process adds to being able to do that. We have looked at the access protocol as being very similar as the access under EUA, because the goal is to provide access to the product to those who need it when they need it.
Right, right. And then maybe a comment and then a question for Suzette. The comment about is really about the H1N1 vaccine during an event, and it's a little bit of a different animal, I would say, than Bacillus anthracis. And the reason is because you had already identified people that were ill with H1N1, which is who got the IV drugs. Whereas the problem with Bacillus anthracis is you don't want them to get ill, because then it carries a very high mortality rate. And so the whole goal behind pre-event MCM is to prevent the disease from occurring. There's been few cases of pulmonary anthracis within the United States in the last couple of years, and it requires a huge amount of healthcare resources. And so if you multiply that by hundreds, it'll easily tip your scales. And so, so just a bit of caution about trying to compare the post-event from H1N1 to a post-event for anthracis, because I think the anthracis would be a much more difficult problem.
Yes, I agree completely. And this was really meant to give a perspective. I was asked to give a
Right.
perspective of being on the ground to try to be
Yep.
doing research post-event. So you're right,
Yeah.
it is not,
Agreed.
it's completely a different scale.
Agree. Some similarities, but Suzette, just a question for you. Did you see any difference in acceptance of vaccine early on in the H1N1 pandemic as opposed to later on? So I'm convinced that once people got comfortable with, hey, H1N1 isn't going to kill everybody, then sort of their interest in getting vaccinated sort of wanes, where early on, when we were getting very conflicting information from Mexico, where it seemed like, hey, this is going to be 1918 all over, there were people clamoring for, why don't we have vaccine? Where is it? How come we don't have it out the door? Did you see any difference between early on in the pandemic and late on in the pandemic?
Absolutely. We saw differences in perception and the desire for vaccine, not only when the priority groups were introduced, but also initially when vaccine began to become available. It was available initially in very limited quantities, so we saw much greater demand. But as vaccine became more readily available and data began to present itself that it was not as virulent as a 1918 type of scenario, we did see a lessening decline rather in the desire for vaccination.
I think my question was a lot answered, but I will ask a piece of it that I think I don't understand. If we came up with a framework, which I think we're going to try to do, of a a pre-outbreak IND kind of research project, we'd almost certainly want to have some piece of it that would be post-episode as well. If that were all approved together and ahead of time, do you think you still would be able to collect the community information, or would you still have the same kind of problems collecting the research data post-epidemic or post-outbreak that you described, for instance, with the influenza? I mean, will we get data that way?
I think it all depends on what we plan for beforehand. I think if we plan to collect data beforehand and have mechanisms to do that, either through clinical networks, have ways to get funds out the door, have ways to have IRB approval in advance, I think if we do enough planning, we can do it.
Well, for instance, the CTSA effort, if you linked somehow something broadly to that, or some way you could envision some ways that you could collect information in a useful way ahead of time.
Yeah, I was only going to comment that from an FDA perspective, to the extent that we have data or scientific evidence ahead of time, helps us evaluate the product with regard to its safety and potential use, but also helps with designing and communicating the information about the product. It's a very different situation when you can say, we have even this little bit of information about safety in children because we have it, versus we don't know anything about the use of the product in children.
Thank you. So this is a question for Dr. McKinney. Bioethicists are accustomed to hearing that African Americans and certain other minority groups don't trust government enough to be enthusiastic about being involved in research or in even some clinical applications of medications that are known to be safe and efficacious. So I'm wondering what your thoughts are for us, because we would like to think that both the benefits of research should be shared among all groups, and also that the risk of research should be shared among all groups. Is there anything you learned from your experience with meningitis vaccine or flu vaccine that could help us understand, for this context and for others that we may deal with in the future, how we can encourage African Americans in particular, but other minority groups, to trust enough to be able to reap the benefits of research and clinical applications of drugs?
Sure. In the situation of H1N1, later in the response effort, when we were trying to increase acceptance of vaccine, particularly among the African American community, we began to engage in a number of community engagement or public engagement meetings and sessions. And from our experience, and I'm actually dealing with this issue now, we're looking at the issue around crisis standards of care and scarce medical resources after large-scale emergencies. I think what I have learned personally is that all of our efforts in each of those two scenarios, we conducted our efforts because it was what we thought we should do. And we didn't, at the beginning, engage the public to get their ideas and their perceptions and their beliefs on what they thought we should be doing. So I think a concerted public engagement effort early on might help us in this effort. It would also, I believe, help members of the public, particularly African American communities and Hispanic communities, feel as though their beliefs and that their voices make a difference. And I think that's what we've been missing previously.
So maybe in an atmosphere in which we are having to think broadly about medical countermeasures, not just for today, but for decades ahead, we should be proactively trying to educate and to engage all
Absolutely.
communities in what they might need to do in order to deal with particular threats such as anthrax or other.
Absolutely.
Yeah.
I believe that all of these communities and these at-risk populations that we're most concerned about have the capacity to understand what they believe is best for them. It's just that their beliefs and their ideas have not been gauged prior.
Thank you.
That actually answers my question, so thank you.
Thank you very much. I have a question for Captain Marr. So if I understood correctly, in your presentation you said that there is not enough scientific evidence today to declare an emergency use authorization for a vaccine for anthrax, right? And that suggests that we need to obtain such evidence before it can be used in children. And the two options are that we undertake such a trial now before such an outbreak or an attack, or that you would initiate such an effort immediately after an attack. So the question for you and other people is there adequate amount of time without loss of significant amount of life or morbidity if you initiate such a trial after the attack, and if so, is it preferable to have such a trial now?
I think the better we can prepare ahead of time to inform the use of the product, the better off we'll be and the smoother the response will go. I know that in our engagement with public health planners, one of the biggest concerns is the dual mechanism for release of the product for pediatrics under IND, for adults under EUA. We are preparing to roll out as quickly as possible a nested research protocol, if that's the only way that we're going to be able to obtain information about use of the product in pediatrics to further inform continued use and how we would continue to use the vaccine in the unfolding response. And then eventually, one can imagine if there's a large city that is exposed to anthrax spores, the spores are not going to go away very easily. So you have to think about exposure even after the immediate exposure of the event. There's a lot of difficulty still and a lot of uncertainty around how would you be able to implement that. I don't think it's ever been done to have that type of a scaled event in a rapid response situation with all the uncertainty, confusion, fear, and then try on top of that to do a clinical research protocol, however simple that protocol may be. The idea, from what I understand, is that when parents bring their children for access to the vaccine, if they elect to have their child vaccinated, imagine as you will, as they're coming out, they're offered the opportunity to enroll their child in this nested protocol for reactogenicity and immunogenicity. How smooth that would go before an event where you have the time to really sit down with the parent, to really talk about the vaccine, to really answer all those questions in a one-on-one situation with time for the parent to sit back and reflect on that before choosing to enroll their child, or being in a situation where their child has received the vaccine because they've potentially been exposed, and I'm trying to save their life, and having to have that conversation in that situation.
This sort of follows from the conversation Anita had with Dr. McKinney, because I do think it is becoming very apparent that part of medical countermeasures has to be community engagement and education. And in that regard, I have two questions. One for Dr. McKinney, whether you think that, given your experience, data would matter at all. Would having some data matter in terms of public acceptance and education? And then secondly, maybe to our other panelists, whether there's been any modeling of what a sort of 25 or 30% acceptance rate for vaccination in the event of a very large-scale outbreak would mean, particularly given the fact for something like anthrax, there isn't even any herd immunity that you could achieve, from what I understand. And then following that, would that kind of data help parents as well? So.
With regards to your first question, I think the benefits of data and whether or not having data would be beneficial for us really would depend on the subgroups of the population in which we were trying to provide that data to. I do believe that there are certain groups within the population who are interested in data and would want to see data before they made any decisions about whether or not to provide the vaccine to their children. However, I think there are other subgroups within the population that won't care very much at all about data and will really stick to what I would classify as misperceptions and things that they've heard about historically. So I think it depends on which group of the population. I think when planning public engagement and community education meetings and sessions, you really have to look at the community that you're going into, the demographics of the members of that community, and tailor those discussions to that demographic.
You know, gosh, and that's really for the others. Any awareness of any modeling of what this, sort of low, because we saw even for H1N1, one of the papers we had, even among healthcare professionals, a 35% compliance rate with vaccinations. It might be even lower with this. Has anybody really even done the kind of modeling of what that would look like if, there are, a million of population someplace exposed?
I'm not aware of any modeling like that having been done.
No, I'm not aware of any modeling that has been done or any
issue.
Yeah.
If I may just add to Dan's question, and this goes to Dr. McKinney. If you're asking, how many people would be interested in data or what sort of data they would be interested in, it seems to me that given the fact that these are basically technical dosing studies, that this isn't going to give parents the kind of information that they would ordinarily be interested in. They want to know whether it's safe and effective.
Absolutely. I would agree with that, but I think for those of us who work in this field, for perhaps parents who work in the healthcare field, that there might be some interest and some value to having that data. But on a larger scale, I agree with you that most parents just want to know whether or not this vaccine is safe.
Mm-hmm.
I guess my question builds on that a little bit, because my understanding is that even in adults, we know it's safe, reasonably safe, but we don't know whether it works post-exposure, right? We don't have data to say this is effective post-exposure in adults. And even the dosing schedule, as I understand it, is an educated guess, if that excuse the word, but I think it is. So the question is, in an event, would we also want to be collecting data from adults? So would we have some of these same challenges because we need data from adults as well as from children?
Yeah. To the first question, I do know that under the rubric of the FEMC, the NIH and CDC have partnered to conduct some studies to look at post-exposure prophylaxis in animals. So that there, if not already, there may be data coming out of that in animals. And then, again, we're back to extrapolation. So from animal to adult and then adult, what does that mean for the child? And could you repeat your second question again?
Well, I guess my second question was, wouldn't we also be interested in collecting data in an event from adults as well as from children, so that all of the challenges of collecting data in a crisis, which I understand are appreciable, would still be there because we'd need data from the adults as well?
Absolutely. And part of that action team that I mentioned earlier, the surveillance, intra-event, we're calling it the intra-event surveillance. So we're actually looking at what can we do ahead of the study for all populations, but also particularly for pediatric and maternal. And we also have an action team that's looking specifically at pediatric and maternal. So we have an overlap of some of the discussion where needed. But we are looking at the fact that regardless, we need to figure out how are we going to monitor and evaluate the use of the product to either further provide information and guidance on clinical decision-making, but also with regard to the safety of the product in the emergency and the efficacy. Is this working? Are we actually protecting people? Are we providing good treatment? Is this hurting? Do we need to pull it back? So we are looking at that, and we would absolutely want to be collecting information. FEMC, I believe, is also looking at the experiences with Peramivir. And one thing I do want to note with Peramivir, and it goes back to that EUA and IND, The EUA is an access mechanism that was designed to allow widespread access. There is no, it does not enable, so to speak, clinical research or any type of research under the EUA. That's not to say that you can't plan to study the use of an EUA product in the population that it's being used. The difficulty with Peramivir is that you released, the product was used under EUA, so it wasn't under research, it was widespread use, and collecting information during that emergency to inform how well the product worked, we've all heard how difficult that was. That's driven a lot of the most recent conversation over how do we do it better the next time.
Now I'll ask the question of Dr. McKinney. Do you think that a process of community engagement in parts of communities that might be at risk of an anthrax exposure, that are historically less trustful of the medical research community, might be in a more salutary posture for accepting a research study post-event, had there been a discussion in the community pre-event of the risks and benefits and the advantage to the community to actually consider a study, again, of the type that we're notionally considering, which would be one that would not address hammer stroke issues of safety or efficacy, but really getting to some of the first steps along that process?
I do agree. I, once again, believe that from our experience, what we have seen, and particularly members of the community that I spoke with directly during the H1N1 response effort, members of the community that had a lot of these misperceptions spoke to me intensively about the fact that the government comes in and tells us what we need to do instead of asking us what we want to do and what we think is best to provide for the health care of our families and ourselves. So I believe as early as we can begin those engagement processes and as frequently as we can engage members of the community, that we will begin to see greater acceptance.
On a flip side of the question about the reluctance of certain communities to participate, we have a question from the audience from Ellen Manning, who's Research Compliance Coordinator at the Medical College of Wisconsin. And she notes from your comment, actually, Captain Marr, that you spoke about not about reluctance, but should we have some concern if in fact we were going to try to enroll children at the time their parents receive a vaccine? Should we have a concern also about essentially the coercive effect of a respected physician in imposing or giving a sense of obligation to the parents of these children?
Yes, I think that's a very real concern. I think this is novel thinking in terms of responding to something like this on this type of a scale with products that we don't have a lot of information on and under regulatory mechanisms that were designed for well-controlled clinical trials and studying a product for generalizable knowledge. So I think those are very real concerns that we have to be thinking about as we're looking at the mechanisms and the plans that we have for responding to an event and taking steps to minimize or mitigate that. But I do think there is going to be a different mindset. The risk-benefit situation, the analysis that we're doing as professionals, as a parent, you're doing that risk-benefit analysis for your child as well. And that analysis is going to be very different in a pre-event setting where there's perhaps maybe in some potential of an event and how much do you believe that that's going to happen and that your child might be affected versus I'm in it right now, my child might have been exposed and we're both getting vaccinated.
Well, actually, we will get to hear from you again, right? It's this afternoon's occasion. So I want to thank all three of you for a very stimulating conversation. And we will take a recess for lunch, returning, when do we return? 1:30. Thank you very much.